Tak dapat dengar, Ahmad.
Hello.
Hello.
Faiza binti Muhammad Tohir for today's CME and the type in care or MC SEEKER. Okay, MC SEEKER. For somatic presentations, I would like to. The session will be started with a 40 minutes lecture by the speaker. You will have the opportunity to submit text question to today's presenter by typing your questions into the chat pane, and you may send your questions at any time during the presentations. We will collect all these questions and address them at the end of the presentation. Ladies and gentlemen, depression and anxiety are common disorder in the primary care setting. They are associated with considerable distress and dysfunction. Majority of them will present with straightforward symptoms, such as feeling depressed, reduced appetite, weight loss, and I would like now to introduce our presenter, Dr. Halkaria, who is a degree from the University of Adelaide, Australia, Saat Malaysia. UKD is the founder of Alam Berhad and clinical director of Alaminda Specialist Clinic Shah Alam. He is also the chairman of the Malaysian Psychiatrist Association Malaysia. Here goes our CME today, trying to look from both perspectives. Are those presented with somatic symptoms are having genuine presentation that require appropriate TLC, or are they mere MC seekers? It's not easy to draw a perfect line between these two, but we are lucky enough to have with us Dr. Hazli to guide us on making the verdict. And the floor is yours, Dr. Hazli. Oh, this one belakang.
Sorry to interrupt, Dr. Hazli, but you're on mute.
Okay, try again. Can you hear me now?
Yes, Dr. Hazli.
Can you hear me? Assalamualaikum. Can you hear me now?
Yes, it's clear. We can hear you.
Okay, okay. Okay, start again. Assalamualaikum warahmatullahi wabarakatuh. I'm Hazli. Thank you, Dr. Faiza, for the kind introduction. And this is part of the program initiated by State of Selangor. And then the Secretariat is a UIA and a few other stakeholders. For us, from MPA, is a part of our activities in sharing and educating. The whole idea is to increase the awareness and also empower the service providers, because we know that psychiatrists cannot do this alone. So the whole idea is about how can we work together. And today, the topic given to me is about somatic presentations of anxiety and depressions. So that is a very interesting, because I know that the first one, Dr. Fazli already talked about the management of anxiety and depression in primary care. So today we are focusing on the somatic symptoms because that is usually the presentation to the primary care. And then how can we tell whether this is really the underlying medical or underlying biological reason? Of course, anxiety and depression is a biological illness. Don't get us wrong there. Yeah? So that's try to look from focusing on the symptoms, physical symptoms that could will have underlying anxiety and depressions disorder that lead for the person to come. Most of them, they keep coming back. So that is one of the red flag that, there could be something there. Yeah. So most of them really, they have a physical and they want MC. Maybe the MC is not enough. They want more than just MC. So that's what we want to find out, what can we offer them? Okay, so the disclaimer, disclosure, tak yalah, do this is no other hidden agenda. Okay, terima kasih for this. So hopefully that for the next 40 minutes, I would like to share a bit about what is psychosomatic, somatic complaint in our clinical practice, and how somatic complaints related to the psychiatric disorder, and what are the management strategy that we can do in dealing with patients who have more physical complaints, but actually the underlying are psychological in nature. When we talk about psychosomatic, the term actually has been around for quite some times, and then there is when we talk about mind and body connection. In fact, nowadays psychosomatic is recognized as a subspecialty in psychiatry. Of course, not in Malaysia lah. But in other countries, yes, it's a part of this. But usually they're also under the consultant liaison psychiatrists as well. Yeah, previously the term like psychosomatic, somatoform disorder, but now the current DSM-5 focus more on the somatic somatic symptoms rather than somatoform, somatosis, because that create this kind of like the non-specific or wooliness of the concept itself. Yeah. So when DSM-5 was introduced, the somatoform disorder was changed to the name becomes somatic symptoms disorder. So in fact, among the psychiatrists also, this is not the diagnosis that we normally give. Yeah, because it's kind of like not feeling good when you want to put the diagnosis that you know that you do not know much. Because in fact, in the DSM-5 is you put under this unexplained or unexamined medical condition. Can we imagine you want to make the diagnosis? It doesn't make us feel good. And the DSM-5 they make some changes, and then they call it somatic symptom disorder and related disorder. Even though it's still not medically unexplained, yeah, but it means that whatever the person's experience are real. So that is something that we have to be mindful about. Most of the time, when we said, "Oh, there's nothing wrong," it's just in your mind. That is really give a different kind of impact or affect them differently. So that is something that we really need to be careful not to say that. So at least if you cannot get anything from here from today, the sharing, if able not to do that, that would be really good. Yeah. So that's I said it's even though we know it's physical complaint, but most of the time we know that we can't really understand what the pathology or the underlying to explain the symptoms that the person has. And then some more when we did the investigation, we do not get or not able to support that. So that is poorly understood and make us not comfortable even to talk more about it. So can you imagine that if psychiatrists, we ourselves, I can appreciate the difficulties that you guys need to face when dealing with this. More important, need to rule out whether this is really physical symptom. Otherwise, it's going to be it's going to lead to much more problem in going to be in court if we're not able to we take the not rule out the underlying physical complaint. Yeah. So because of that, they has been neglected. And then, but the problems with that, they do not receive the treatment or the management that they deserve. Yeah. So these are the symptoms in clinical practice. Of course, we know that most of them have some positive results of investigation to suggest or to explain, but it's not fully explained. That's the reason why it's still considered unexplained medical condition. 25 to 50% more serious, 30 to 75% remain medically unexplained until the end, and the last part, 16 to 30% bothered the patient a lot. So this is something that we really need to put something important for us to care for. Okay, patients commonly present to their primary care complaining about physical symptoms. Yes, if they, even though they have psychological symptoms, they normally complain about physical symptoms, even more among Asian in our culture. More often than not, medical workup fail to show the underlying pathology. These prevalent somatic symptoms lead to multiple visit to the clinic, to the services, to the hospital. But unfortunately, some of them, when they refer to us, to psychiatrists, some of them do not fulfill the criteria. So they really frustrated even after they agree to follow the advice by the primary care, by other specialists to come to see psychiatrist. So for me, this somatic symptoms is really something that has been ignored for quite some time, and we have to do something about it. So it's something that, like appendix, tak ada apa fungsi. But again, this one is something that affect them and then affect their quality of life. That's something that we have to consider as an important thing that we want to do about it. Okay. In terms of the, now I use the word somatization. Somatization actually is the same thing as somatic complaint, but it's somatize it. But when we talk about somatization, the underlying is psychological. So, but when we somatic complaint at this moment, I want to the concept that my understanding for the people with have this somatic complaint or somatization, they have both. They have this some pathology, but not enough to explain. But the underlying psychopathology make the perception or the experience of the symptom is more than what we expected looking at the underlying psychopathology. It can be in the acute somatization, relapsing, and the chronic. The chronic one is the one that really has affected their quality of life and also make them use a lot of services, medical services. Not so much on the psychiatric part because they usually do not want to come to sick because their physicals are really real to them. Despite all the intensive investigation and explanation by the primary care doctors, by the other specialists, but they rarely come early. So that the whole idea is if we able to do that, in fact, if the primary care able to detect that and do something about it, not necessarily refer to psychiatrists, there are a few things that we can do actually. So that is how to understand how the symptoms can lead to the change in the connection, the emotion, and then make the symptoms even worse physically. Then of course lead to the changes in their behavior. So we can't really we can't really separate the physical symptoms from psychological symptoms. That is the fact. This pandemic, this COVID-19, confirm that. See, the viral, the bacteria, the viral infection, we're supposed to, not viral, the COVID-19 infection that caused a lot of physical symptoms, but at the same time lead to so much manifestation of psychological symptoms. So that is how the symptoms, physical symptoms started initially, affect the thinking and the emotion, then further enhance the experience of physical symptoms. This vicious cycle lead to them to having all this kind of health-seeking behavior, and then did a lot of unnecessary strategies to get rid of the physical symptoms. Unfortunately, most of them did not lead to the improvement of the symptom, then make them having the symptoms of psychological disorders, mainly depressions and anxiety. So in order for us to understand what made the person a higher risk to develop this somatic complaint, the somatization, we can look from the predisposing, precipitating, and perpetuating. The predisposing, some people who have a history of past history of chronic illnesses that has higher, the trauma during childhood, the ACE, remember the ACE, adverse childhood adversity, the higher the score, the more likely they're going to have the somatic complaint. And of course, if they have a psychiatric condition and there are some kind of characteristic or personality trait that make them predisposed to be more anxious or kind of a high sensitivity to the changes in their body, precipitating the medical illness. Yeah, for example, the COVID, for those who have had COVID, and then can lead them to have more physical complaints after the COVID discovered. This may also explain some of the symptoms of the long COVID that experienced by our patients. The perpetuating the chronic stressor, maladaptive coping skill. So that is the perpetuating factors that make the person continue. That's something that we can do also to reduce the experience of suffering that they have because of having these somatic complaints of this. Because I'm not talking about the somatoform disorder, but the somatic complaints of patients that could have depression, anxiety. But most of us, we are not exploring the possibility that people who come to us with physical complaint could have depression, anxiety. That's something that the whole idea about this sharing is about. How can we increase our sensitivity to the red flag that we are able to do some kind of intervention to reduce and then to treat the anxiety and depression. That is an important thing for us to do. Then most of psychiatric condition, they have physical symptoms. It's not just psychological, even the depression itself. But the reason I highlight the panic disorder and generalized anxiety disorder, there are two anxiety disorder that sometimes we very much focusing on the physical symptom because they normally have physical symptoms in their presentation, which lead to delay in getting the diagnosis of panic disorder and GAD. They could have the medical condition, but at the same time, they could have comorbidities with panic disorder, generalized anxiety disorder. MDD, I think we are getting better in screening them and diagnose them and detect that early. OCD is even more easier if the person share with us. But somatoform disorder, as I said, is somatic symptoms, specific psychiatric disorder, which somatic symptoms is the predominant. Of course, they have that. That one I don't want to focus. I just want to highlight that this anxiety disorder, generalized anxiety, panic disorder, generalized anxiety disorder, MDD, something that we need to focus. If we want to focus so much, we're not able to cope, and then we not want to do it. So that the whole idea is depression, panic disorder, GAD is something that I think is worse for us to focus on, and then we can do a lot of prevention, or at least secondary prevention and tertiary prevention. And when talking about the anxiety disorder, depressions, there are common symptoms that shared by both the disorder. Yeah, for example, in this irritability, difficulty, concentration, restlessness, fatigue, but both of them also share somatic complaint. They have physical complaint, all the symptoms of gastric pain, headache, or the indigestion, muscle pain, cramp. So the changes in menses also good related to, because there's the relationship between our body with the symptoms of depressions. From the study by Simon et al., 69% of depressed patients presented with somatic complaint, which then complicate the diagnosis of their physical complaint, of course. Yeah. So that is something that when we see the patient, of course, we talk about the management, but again, be mindful about the possibility of this person having underlying psychological issues that can be, that something can be done. And about half of patients with MDD have comorbid anxiety disorder. Patients with comorbid MDD and anxiety disorder, they has a poorer prognosis. The response to treatment not as good as if they only have one, and they have lower quality of life as a result of poor impairment, and something that we have to be mindful as well, the increase the suicidality. If someone depressed, they don't have the energy, they don't have the the power to do it. But for those who have mixed anxiety and depression, they usually have this agitated depression that make them feel so uncomfortable. The mood is really not just low mood. They have a very this kind of someone like have akathisia or restlessness that lead to the increased suicidality. That is has been documented. So for those who have depression, is bad, or having anxiety disorder also bad. If you can imagine if they have both. So that is the reason people who have somatic complaint, most likely they could have both. So the reason that I want to highlight why it's important for us to focus on the somatic complaint, because the possibility of this person have both depression and anxiety when they presented to us, and if we can detect early, we can do something about it. We are going to do a lot more to our patient. The so okay, dia suruh saya minum dulu. Ya. Okay, so I want to talk a little bit about anxiety, because for me, anxiety is something that we not really, how to say, we know what it is, but we not really good in differentiate between the normal experience of anxiety, the abnormal experience. Even as the professional having difficulties to separate the two, to differentiate the two. And we know that everyone, human being, we have to be to have this ability to feel anxious, because that is what part of the normal mood. Yeah. Then in fact, this is our defenses. This is the way that we able to survive. But the problem is when this anxiety become pathological, when it's become excessive, and then it's too frequent, and then it's inappropriate to that what really happened, and that then is impact the functionality of what we want to do. So that is the difference between being anxious and having anxiety. So for it's like when we are facing something is a threat, we respond that by activating our autonomic nervous system, and we have the having all the symptoms for us to survive, and then the parasympathetic will activate it, and then we have a period to recover. That's normal. But the problem is, if the threat is being perceived as a threat, even if it's not, and then we activate the autonomic nervous system for the reason that not for survival. And so the perceived anxiety is what makes us go into the vicious cycle. Or we have the past experience that make us be more careful in order for us to protect ourselves from experience the severe anxiety that we experienced before. So that all these kind of our brain become overactive, overprotective, become more insecure just to protect us. That could explain what made the normal anxiety become pathological. And then when we're talking about anxiety disorder, all these symptoms of anxiety and then has persistent, it's chronic, and may affect their functionality. Unfortunately, that's happened to us. We have to admit this. We are not comfortable to show this. We're afraid that people will have different perception or judge us when we show that we are not able to face it. We're afraid this considered as weakness, and because of that, people who have this anxiety, they always try to hide it. And the thing that initially start as a stress, yes, is adjusting to the situation, and then is when it's not if the person has the risk, and then all has the factors to develop the symptom of anxiety disorder. It's not their fault. It's nothing to do with their ability to think positive or not. Because once the person has the risk, and then the symptoms, this has become the disorder. So that is something that we are also not really able to convince to our patients, that make them not able to understand to the relationship with the somatic symptoms that they have, the physical symptoms with the underlying psychopathology from the psychological point of view. Less than 50% of patients with anxiety disorder are recognized as having any kind of psychological problem. Kesian kan? Bukan not just recognize not having the physical symptoms too is related to psychological symptoms, meaning that they are not recognized that as having a psychological problems. So there is a lack of understanding. Even sometimes when they come to a psychiatrist, even we also having difficulties to detect that and then to make a diagnosis again, because they are very good in hiding it. They are not have the trust yet to show what they are, to tell what really what they experience it. And then some more, even among us, we are very quick in dismiss or try to find or relate or to match whatever they experience with one reason for them to develop that. So that is something that that we have to, again, to be mindful. And then, of course, in this era, which we are practicing the defensive medicine, we have to do everything and end up create more anxiety when they come to the results, and while waiting for the result. It's really something that is we cannot imagine, that cannot experience that we if we don't have the anxiety. So it's important for us to at least to be aware about it. So at least show some empathy, not just dismiss, and then there is a make the experience even worse. We know that they are very good. They are very good pretender. They try very hard. So when they come to see us, most of the time when they cannot hold it anymore. And then even when they have this anxiety, if they mild, we think, oh, tak ada apa-apa, just part of the stress saja, just adjusting. When they have the moderate level of anxiety, when they start to have the physical complaint, then the somatization we are focused so much on the physical complaint, despite there is no evidence to support that. And when they are too bad, the too long, and then they come to see psychiatrists, they don't come with the anxiety symptoms only. They come with the depression. They come with all these substance use, and then we ignore the anxiety symptom, the anxiety disorder. We treat what come to see us, which is a much bigger depression, substance, and end up they are not being taken care of. So that is my dear friends, it's important for us to use this physical complaint, this somatic complaint, as a way for us to link to this the underlying anxiety, which is much easier to understand compared if we want to link the somatic complaint with depression. So that is my take. Another take-home message. When the physical somatic complaint is, for me, I want to highlight. I want us to focus, to give more attention to the anxiety symptoms that could lead them to have more or exaggerated response. Sorry to use the exaggerated response to the physical pathology that they have. So come to the management, yeah. So what important for us to do all the physical examination? Yes. So I think you guys are better to do that. That's important when get a referral. I have to know who are the primary care refer to me, because they are good in doing physical examination. Not because lah, psychiatry bukan dah lama tak buat kan. You guys are much better. So it's important, even when it comes to us, if the somatic complaints are the main presenting complaints are, we have to do that again. We have to examine. We have to to treat that is some in case is missing, because there is no way that we want to jump to say that it's just a somatoform or just depression or anxiety without we really do rule out the physical the causes for the symptoms that they have. If no organic causes exist, very often is the individual. Of course, we want to focus what the person need and we want to integrate the pharmacotherapy and non-pharmacotherapy. So medication, yes, is important when we find what are the underlying reasons for them to have the somatic complaint. But if the causes is still not being explained, I think we need to refer. Of course, after even we come to see us, and then I felt, oh, there is no reason for them to have this physical complaint from the psychological perspective. We have to refer to try to find out what could be the underlying. But most of the time, yes, when it referred to us, we know. And then it turned out to be, yes, there are underlying psychological symptoms, psychological illness that make the physical symptoms much more obvious to them. So what I'm trying to say is still we cannot replace. Yes, we can do screening. There are like PHQ 15 we can use. Yeah, we're familiar with PHQ 9, but PHQ 15 is something that we can use for what for somatic complaint. But nothing can replace the clinical interview. We need to understand the symptoms. We have to find whether it makes sense, this syndrome, and then to understand that. But for us, when it comes, we need to verify and then or to rule out that the depression and anxiety contribute for the person to have this physical or somatic complaint, and then try to find out what can be done. Okay, so then when we said that the best fit for the person is not just medication, in most cases when the person has somatoform disorder or somatization, the medication alone is not. But most of the time, because of they have underlying at least subsyndromal anxiety disorder or depression, that make the medication help them somehow, partially most of the time. So these are a few strategies that we can do. Yeah, one is we avoid the temptation to send for more investigation. Most of the time, the investigations are for more our security or our vulnerability. Of course, they ask for it. When the more they say, and then they need that, even more important for us to consider the underlying anxiety disorder for them to push for us to do that. And then we need to, yeah, of course, to talk to the patient, to educate them. The problem is how to educate them, how to share with them. That actually really important. The pacing, when to talk about it, when to say, and then sometimes the use of words that we use influence whether they are going to be on our side or not. And we have to see that how much the burden that this has impact to the person. This one is important to do that, because that is in a way make us show that we are empathy to them, because the functionality is how the thing that we can agree on. The common ground that we can work with, and then that is how we can collaborate with them. The reason I highlight the red, because to actually to request you guys to do screening for the anxiety and depression, do that PSQ, GAD. I think it's good enough. It's good enough to do that, and then yeah, and then I really believe primary care can treat depression and anxiety. Can only the complicated one, or only the little bit unsure, it can refer to us, get the diagnosis, and we can send back. That's how the thing that we can do together. So we're talking about medication, yeah. When we're talking about medication, again, when depression, anxiety, I'm sure Dr. Fazli have mentioned about this, yeah. Our friend of this neurotransmitter, serotonin, dopamine, or adrenaline. Yeah, because these have a different role in again depend on the which symptoms that the patient presented. So that's the reason I mentioned earlier, the clinical interview, the history taking, important for us to know the symptoms and then put in the symptoms into the group. So then to help us to know which neurotransmitter that we want to utilize more. For example, the noradrenaline for more energy lethargy, the illness. If someone complains, so tiredness, the physical fatigue, so that we need to have the medication that have more on this part, or the cognitive, the motivations, or dopamine. Serotonin is yes, this is the one who have this mood, anxiety. But the whole idea is not as easy, as clear cut as this, because the one we do not know what really happen when the medication goes into the bodies. Again, this is the general kind of very general rules to know which patients will be responded better to SSRI or SNRI. Again, as I mentioned earlier, for noradrenaline, it's more on the energy, on this kind of like alertness, but the serotonin more on the mood, anxiety, anything like that. But again, we have to remember, most people who have these physical somatic complaints with the underlying anxiety, especially anxiety symptoms, they are very sensitive to the medication. They are usually develop side effect much higher. The chance for them to develop side effects much higher. In fact, we need to slowly starting the dose. My advice is always half of the recommended initial dose of the medication that we're going to start. Why? Because they have these physical symptoms. They also already long in history of want to get better, and then they are come to see us. Most of the time, they already demoralized. They already tired of having the symptoms. So that is important also for us to realize that. Yeah. So the important also for us to look from the impact. The economic impact means that doing more investigation, then more and more others complementary and supplementary treatment. I'm pretty sure they have tried a lot already. And then when we want to start the medication, so that is one of the issue, because we say, oh, this medication want to treat your anxiety, want to treat your depression, but sometimes they do not feel depressed, they do not experience it. Why? Because their symptoms of anxiety or depression has been transferred into the physical complaint, somatic complaint. That's the reason sometimes they say, oh, I'm not that depressed, I'm not that anxious. That another difficulties that we're going to face. So then they said that some of them, and then even though we don't want to tell that this is antidepressant, they will find it out. They will go to internet and find out, and then they did not trust us. You know that some of the specialists, the gastroenterologists, I know he used the antidepressant, but he did not name as antidepressant, but instead of name it as a mood modulator. I think we should do that also. It's a mood regulator. It doesn't look like a antidepressant per se. But again, all it come back to communications, our education with our patient. They are good. Most of them want to get better. Yeah. And then how about the role of benzodiazepine? Yes, there is a role of benzodiazepine. Sometimes we are too afraid of this. We create fear, unnecessary fear. The problem is if it take too long, it's a higher dose. And most of the time we have to explain, especially when we start the medications, antidepressant or anti-anxiety, the SSRI, SNRI, and other agent, we need to start with benzodiazepine as well, at least to cover the first 1 week or 2 weeks before the medication to start. And then again, this is need to be educated, to be discussed, to share with our patient. And then, of course, we also mentioned that this not just medication alone, but other non-pharmacological. However, we have to wait to do that. And most of us also, sometimes we cannot do ourselves. We have to refer as well. Then you guys also can do that. So, okay. This is the study. There is no specific for the somatization or somatic complaints among patients with depressions or anxiety disorder. But anxious depressed people, patients with anxious depressed, there are a few studies have done, and then usually associated with poor outcome. So meaning what? Meaning don't give up on them. Meaning that we have to be more aggressive. We have to detect early. We have to combine more with other than medication. Okay. So when talking again, despite I say got evidence, but it's not as much as other subtypes of depression. But most of the time we start with SSRI, SNRI. So I think now SSRI, SNRI is cheap, right? Have generic. Please use it. And then remember, I always combine with benzodiazepine at least the first 2 weeks, and then monitor that carefully. Give the support. They like to come back, so don't spend too much time, but more frequent. That is what you guys have able to do. So other things, the practical thing there, schedule time, the appointment. I know that 4 to 6 weeks for us, but again, for you, you can afford to see it earlier. And then they like to see you guys more than see us actually. Yeah, especially the one who have physical complaint with the somatic symptoms. And then we need to explain that there may not be reason for the symptoms, but again, there are something that may not be able to explain now, but whatever the experience are real. So we need to educate. We need to link back how the symptoms biological lead to the psychological. Can use this COVID-19 and then talk about this the stress situation, the autonomic nervous system. Again, that is able to do it because we learned that during our secondary school. Nowadays, they learn in primary school already. And then please to avoid using the terms like your symptoms are only in your head. There's nothing, we cannot find nothing wrong with you. And then if we cannot find anything wrong with you, we cannot do anything with it. No, supportive. What we can do is continue to support that and try to, at least we can tell them not to do any more investigation. But yeah, this is important. Yeah, please ask whether they have other, they're taking not necessarily illegal, but it's something that they do not tell us for the weight reduction, for some increased performance in other system. They did not tell us, but we have to ask. Yep. Okay, last slide, guys. So important for us to acknowledge the symptoms. Let them tell us their symptoms. Yeah. Let them, we explore their symptoms and try to understand their experience. Non-pharmacological, like CBT, not necessarily CBT. In fact, the supportive psychotherapy is also able to provide some relief, reduce the symptoms experience when we provide that to them. The initial treatment must be effective and relief for patient because they don't want a lot. They don't want to have a big changes, but something they can feel it. They can see it. So that is important for us to. That's the reason, the secret. What is the secret? The secret is that's why important to use benzo. But again, explanation, educate them, and then most of them, majority of them actually don't really want. They're also afraid of being dependent on anything, not just benzodiazepine. The whole idea is for me want to highlight how the way that we engage them, the way we address them, the way we see them. That's what we need. That's what they need. That's what we need to do. This therapeutic alliance is important. I know that they come for MC, they keep coming because what they probably want is a TLC, tender loving care from us that we can offer through having a very strong therapeutic alliance with them. Having said that, we also have to know our limits. Then we are not able to do so. We have to be honest with them, and then we find how can we help them by refer and then working together with them, so that they are able to feel that they are being supported, even though they still have the symptoms. So guys, my dear colleague, so we can do something about it. And then please ask me any question. If you need to clarify. At the end of the day, please don't forget that we are human, they are human, and why don't we help each other? So that the whole idea. At the same time, of course, like making money kan. Kalau tidak, nak makan macam mana? Okay, with that, thank you so much.
Okay, thank you, Dr. Hazli. It was very enlightening and eye-opening to all of us. Okay, We have one question from Dr. Kim Yang Chung. Hi, Dr. Hazli. What is your opinion on the use of benzodiazepine in anxiety patient? I have patient develop BDZ use. I have patient develop BDZ use disorder and difficult to titrate down BDZ, even on intermediate and long-acting BDZ.
Okay. Okay, thank you for the question. I think the question is a very good. I mean, I expected this question also. Benzodiazepine, of course, first and foremost, we have to know benzodiazepine. There are many benzodiazepine. Yeah, we have a lot of them. And then if we know them, they are not the same. They have a different characteristic. For example, clonazepam, the Rivotril, they have some element of muscle relaxant there. You know, and then we interesting also. Most of our patients, they have preference which benzodiazepine they like to be friend with. But of course, we know the shortest duration of action, the fastest onset of action, the higher the chance for the person to be dependent. But again, we know also there we have to understand there are certain personality. There is a certain thing that happened in the past, in the history that we collected. We can tell whether this person is a high risk for the dependency as well. So the whole idea is we can't really just say that, oh, benzodiazepine is good, benzodiazepine not good. Good into which patient, what type of patient, what kind of benzodiazepine that we should. All of these, it can be done if we explain, have a good discussion with, oh, mana ada masa nak ada discussion? Ya, tak ada masa. Tapi nanti next time datang hanya fokus on benzodiazepine je. 15 minutes. Ada je masa. Jangan cakap benda lain. Jangan cakap pasal bini nombor 2 dia, bini nombor 3 dia. Fokus on benzodiazepine je. Example. So the whole idea is we want to see what, if we really understand the mechanism and then the role of that medication and explain to the patient what is the maximum dose for each of them. For me, the one who come to see me, they're afraid of taking benzo rather than want to take benzo. The one who take benzo a lot, they go to see Dr. Fazli because they have a problem with their dependence or not. But most of the time, the patient who come to see me, they are naive in all the medication. For me, there's the opportunity for us to use this and opportunity to tell them, to educate them, to dispel some of the myths that they got from the internet. So, for example, if you cannot use Xanax as to help them sleep, that is ridiculous to use Xanax because Xanax is only short one, and then they cannot sustain the sleep. But they like to take to do that because they want to take it and then they can sleep straight away. And then we have to tell them, no, cannot. If you want to do that, we have to take the risk that you're going to be dependent. You nak ke? Tak nak janganlah ambil contoh yang macam tu. But again, we have to explain to them the reason that we are concerned. But again, we said that for people who have panic attack, wow, Xanax is needed. Kita pula jangan sampai tu dan kena ambil at the right time before it's reach the climax. Otherwise, it's not going to be much good to the person. So, what I'm trying to say, we have to increase our knowledge, our ability in understanding what benzodiazepine is all about, rather than just simply say it's bad, just because we do not know much about what it does to our patient. For those who have a panic attack when they take benzodiazepine, wow, lagi bagus daripada doa, zikir apa semua tu. Bukan saya kata zikir tak bagus, apa nak zikir apa, kalau dapat panic attack lupa nak zikir apa semua tu. Jadi ambil Xanax dulu, lepas tu zikir lah. That's how we do it. Ini kan sebab kita tak pernah dapat panic attack lah, kita cakap macam-macam pasal yang ni. That's the whole idea. Sorry, bukannya marah, bukan marah. Lagi nak kena ambil Xanax pula, marah dah ni. Bukan.
Okay, one more question, Doctor. How to differentiate between GAD with depression versus MDD with anxious distress?
Wow. Ini soalan bagus ni. Ini soalan budak masters mana tanya ni ya. Bagus ni. Ya, betul. Betul. That's a very good question because major depressive disorder, clinical depression, people who also have anxiety symptoms. But we have to know whether the anxiety symptoms are part of the depression or the anxiety symptoms is a part of the another um, anxiety disorder. Meaning that whether the person who are anxious, depressed ni, they are MDD under they are having major depressive disorder under the subtypes of anxious distress. Or this person have anxiety, have a MDD with comorbid of generalized anxiety disorder. Okay, sebab itu kita kena tanya cause the longitudinal history. People with JAD, with comorbid MDD, normally the JAD started earlier. They have this kind of perfectionism, they have this rumination, they always think a lot, most of the time they already have that prior to the first episode of major depression. But when they have the depressive episode, most of the time the symptoms of JAD tu dia ada background sikit. And then when the depression has been lifted, baru yang nampak. Jadi baru kita, oh ini. Whereas patient with anxious distress, they have also, actually there is a DSM-5, there ada kriteria untuk anxious distress tu. Dia tak boleh keep up, dia ada macam tu. Adalah, dia ada 5 out of that. Tak apa. What I'm trying to say is, dia itu bila kita treat the depression, apa semua tu, the symptoms normally also disappear. Tapi if the person have MDD comorbid with JAD, bila kita treat dia punya depression, the JAD tu barulah nampak, barulah dia ni, oh yang ni. Barulah dia, orang lain bila orang nak datang rumah, dia tak boleh datang rumah, dia kena kemas apa-apa semua, cantik apa semua. Kena ni, sebelum waktu dia depressed, dia tak apalah, dia tak payah kemas. Tapi bila dah depression ni, dia mulalah ni kisah nanti macam mana, nanti orang ambil gambar masuk dalam social media, nampak kitchen dia batak ni, macam tu lah. JAD lah tu. Jadi JAD, meaning what? Meaning that we really need to consider the CBT, the psychotherapy is and then at least we need to look into the trait that contribute them to have the depressive episode. We don't want to have depression anymore, because that is having another disorder, JAD, predisposed or increase the risk for the person to have other psychiatric disorder.
So,
Jadi
Doctor,
tu elemen of prevention dah kat situ.
so do you mean that
Harap menjawab soalan lah. Kalau jawab nanti saya cuba lagi.
okay, so do you mean that they can be managed at the primary care setting, or should they be referred to psychiatrists? Because it's quite difficult to differentiate.
Okay, kenapa? Dah maksudnya lagi kita detect lagi, the earlier we detect, the earlier the much easier for us to manage. It's of course lah can manage at primary care. Kena lah, sebab itu kenapa kita buat CME ni apa semua ni nak bagi manage kat primary care lah. Oh, the problem is when we wait too long and then become a severe and then have all this comorbidity with all this kind of thing and then make it difficult kan. That's why and then kita pula benda yang when we see the patient who are having all this, kita nak treat nak buat semua, tak payahlah treat lah dengan yang simple-simple dulu. The problem is simple, tak payahlah. Ini adjustment je. Padahal when we start treating the person with some adjustment disorder kind of thing and then come up with some non-pharmacological, that's a can make us much more comfortable to do that. And then that is, I think the whole idea is how to make us more comfortable when we see more and then make more some kind of error. Error tu tak susah, ubat antidepressant, ubat ni bukannya bahaya sangat pun. Paling-paling pun dia dapat somatic side effect je pun. Cuma all these things can be done by kita share, educate, and then we use the script, and then we monitor. Senang sangat nak treat ni. Dan yang mana yang kita perlu, kita hantarlah kepada clinical psychologist, hantar to counselor, and then we are managed on that. The case manager. That's something that we can do. And then most important thing is don't stretching. You make it, they come more often. No, and the simple answer, yes. And then that's why I think we need to work to do it together first until primary care much more comfortable, and then can do that. And then that is the whole idea, because I think primary care is a better platform, better avenue, is a much better position to treat depression and anxiety, especially at their mild and moderate stage.
Okay, Doctor, one last question lah, Doctor.
Hmm.
Our title tadi TLC or MC seeker. Then I think this is quite relatable to all of us. At the first presentation, at the first encounter, how do
Okay.
we manage our
Betul,
stigma
betul.
to the patient?
Kita tahu, kita dah ni kan, Faiza, the problem with us, bila orang cakap lah ni, kita assume dia nak MC dah pun. Dia tambah pula tengok muka dia ni, dah main beberapa kali dah. Bulan ni tak, betul, kita boleh kata, you tak, bulan ni datang first time datang bulan ni, selalunya muka you 3 kali untuk ambil MC. So the whole idea, I mean, I know there are few patients are doing that. They did for MC, but not many actually. Some are then, and then if they come for MC frequently, couldn't it be the way for them to tell us, I need TLC? That is a way for them to tell us, asking me more about what made me coming back to you for MC. Because secara fitrahnya kan, Faiza, kita ni nak buat baik, kita ni nak kerja, kita nak curi tulang tu tak banyak. Dan curi tulang, yang suka curi tulang MC ni pun, I'm pretty sure something there in their workplace that make them want to be away from that. Most of us, we use avoidance as the first step when we face something that as a threat to us or that make us feel not comfortable. MC is the avoidance, the way they want to avoid. And then we ask them, that is the important for for us to be able to say that there is something that they want to tell me. And then I want to, tapi kita kata, masa tak ada, banyak-banyak pun, kena charge pun banyak tu juga, bukannya boleh ni. Yeah, betul. That's why I say we have to figure out how to do that also, how to reward for something that we do. Okay, for me, at least this is last from me. Kalau ni, how to engage the person in when they come. I use this AEIOU, as simple as AEIOU. A stand for alignment, meaning that we and this person have to be in a common side. You tak perlu dapat MC, I nak MC. Memang bergaduh lah. I'm pretty sure that you are not in your best state to work. I agree with that. You agree tak? Yes, agree. And then alignment. E kan, empathy. It's not kita kata, janganlah kita kata, dia ni nak curi tulang apa. No, must be something buatkan you tak boleh nak pergi kerja, contohnya. Empathy is important. I apa? I sebelum kita nak bersyarah ke, nak bagi solution, nak apa, kita tanyalah, invite, is it okay? And then bagi kita kena dapat permission kan. O is a offer all the option. Yang ni. Okay, ni. Maksud dia MC. Okay, berapa kali lagi. Lepas ni pun I concern juga pasal ni. Lepas tu you tu apa? You tu bukan untuk dia saja, untuk kita juga. You tu for us. So when we think about this, we are know how to engage our patient, our client yang datang, dan kita don't terus kata dia ni nak MC je kot. Ataupun dia masuk muka, tengok muka dia, nak MC berapa hari kali ni? Macam tu pula. There is a judging already. So it come back to the therapeutic alliance that we need to develop with our patient, our clients. So it's nothing wrong about giving MC and also giving TLC to them. Why can't we do that? So that is my question lah. Why can't we do that?
We have learned so much hari ni, Doktor. Terlalu banyak. Tapi yang paling saya suka sekali akronim AEIOU tu. Itu saya rasa boleh pakai untuk semua patients kan. Not only for the
bukannya Faizal, boleh pakai untuk semua patient, pakai untuk husband. Kalau husband Faizal isap rokok, gunakan AEIOU tu.
Okay, untuk husband pun boleh AEIOU. Okay, Doktor. Alright, terima kasih banyak-banyak from the organizer and from everyone, from all attendees that have listened to you for the past 1 hour. We have learned a lot. Thank you very much. And I hope we will meet again in other avenue. And from the bottom of our heart, thank you again, Dr. Hazli. All right. Thank you, everyone. And don't forget to tune in to our next CME next week. Okay. And that's all from me. And Assalamualaikum and goodbye.